Welcome to the Deep Dive. If you need a shortcut to being truly well-informed, if you want to cut through the noise and understand the crucial complex details that really shape our world, then this is your destination.
Yeah, we take on the toughest topics.
We do, and we give you the essential knowledge quickly and thoroughly. If that sounds like a good deal, make sure you hit that subscribe button right now.
Definitely subscribe. Today, we are staring down the barrel of, well, a massive financial and policy collision. It's scheduled for 2026.
A collision, that sounds dramatic.
It is. We've synthesized the latest research analyzing the acceleration of drug costs, the tangled mess of the U.S. pharmaceutical supply chain, and the immediate kind of contradictory impacts of implementing the Inflation Reduction Act, or IRA.
And the projections,
Yeah.
wow, they are eye-watering. Analysts are predicting double-digit increases for overall prescription drug costs in 2026.
Double digits.
Yeah, this is the highest annual projection we've seen in over a decade. That's
Oh.
why we're here, right, to figure this out.
Exactly. And the overwhelming driver behind this cost spike, it's the category of specialty medications.
Okay, special demands.
These are the high-cost, high-complexity therapies, essential for treating severe, chronic, or rare conditions, ranging from advanced cancers and multiple sclerosis to rheumatoid arthritis.
Got it. So our mission today is to unpack this crisis. We want to give you a clear map of what's happening.
Right.
We are analyzing the convergence of, well, these amazing therapeutic breakthroughs, cell and gene therapies, the GLP-1 weight loss drugs.
Which are everywhere now.
Exactly. And how those clash with the structural market distortion that the IRA is already causing,
Yeah.
even before its major provisions fully kick in.
And at the heart of this analysis is the core economic failure that plagues American healthcare: financial toxicity.
Financial toxicity.
There you go.
Explain that a bit more.
It's how patients' out-of-pocket costs are calculated. They're based on these massively inflated list prices, the wholesale acquisition cost, or WAC. Critically, this is not the significantly lower net cost that the insurer ultimately pays after negotiating these complex, confidential rebates.
So there's the list price and then the real price the insurer pays after discounts.
Precisely. And the patient pays based on the list price?
That disconnect, paying a percentage of a price that literally no one pays, that's what's fueling this crisis.
That's it. It harms patients, compromises adherence, meaning people don't take their meds, and it destabilizes the entire healthcare economy. We need to follow the money, and we need to understand the policy.
Okay, let's do it. Let's unpack this entire system, starting with the drugs themselves. We hear the term specialty drug all the time, usually coupled with a massive price tag. But maybe we can start basic. What exactly defines a drug as specialty in the eyes of the healthcare system?
Right, well, it's really a designation based on a few key things: complexity, the condition it treats, and the care model needed. Functionally, specialty drugs, they share several characteristics. They treat serious, chronic, or rare diseases, often conditions that were historically untreatable or needed really continuous, aggressive management.
So big impact diseases.
Big impact. And they require specialized handling, maybe storage like refrigeration or complex administration. Think drugs delivered via injection or infusion, sometimes in a clinic or hospital.
Not just picking up a pill with a local pharmacy.
Often not, no. And they usually need specialized handling, maybe monitoring. Sometimes they're started or managed by specialists, not just a primary care doc.
And then there's the cost threshold. That brings it all home, doesn't it?
Absolutely. The high cost is the final definitive characteristic. For instance, Medicare officially classifies any pharmaceutical costing $600 or more per month as a specialty drug.
$600 a month, okay.
Yeah, that's a pretty clear boundary between these and your standard high-volume retail prescriptions.
So, okay, these drugs represent the pinnacle of medical science, right? They're saving lives, treating previously hopeless conditions. Why are those list prices so astronomical right out of the gate? Is it just profit maximization, or are there huge intrinsic drivers pushing that cost up?
It's likely both, let's be honest. But we absolutely have to recognize the immense intrinsic drivers first, what we might call the manufacturer's economic imperative.
Imperative how?
Drug development is a scientific gamble. It's incredibly lengthy, and it demands staggering financial investment. Just look at the numbers.
Okay.
The mean cost of developing just one new drug. And this accounts for the cost of capital and, crucially, all the inevitable failures that never make it.
Right, the ones that don't pan out.
Exactly. That cost was estimated between 2000 and 2018 at $879.3 million.
Wow. Nearly $1 billion to shepherd one successful compound through research, trials, approval. That's incredible.
It is, and that investment has only intensified. Last year alone, biopharma R&D spending topped $100 billion. That's a remarkable 44% increase over the previous year.
$100 billion. And where is that massive investment going?
Overwhelmingly into specialization. Specialty therapies accounted for a shocking 93% of all new U.S. drug launches in 2024.
93%.
Yeah, so that tells you the market is focused almost exclusively on complex, high-impact, and yes, high-cost innovation.
That focus on complexity leads us right into the orphan drug dilemma, doesn't it? That seems like a perfect example of how the R&D structure hits the final price.
It's a core economic issue and, frankly, an ethical balancing act, too. Rare diseases affect about 30 million Americans.
Which sounds like a lot, but spread across many different rare conditions.
Exactly. So when a manufacturer spends, say, $1 billion developing a therapy, they have to recover that investment from the patient pool.
Makes sense.
Now, if a drug targets a common condition like high blood pressure, they can spread that billion-dollar cost across tens of millions of people. Keeps the per-unit cost relatively low. But if it's an orphan drug for a disease affecting only maybe a few thousand people nationwide, the math just forces the per-patient cost way, way up. The only way to recoup that huge R&D investment is to charge a premium per dose.
And that ability to charge a premium, that's legally protected for a time, right? Through intellectual property.
That's correct. Patents and things called regulatory exclusivities grant manufacturers a temporary monopoly. It typically lasts around 20 years.
A monopoly to sell it exclusively.
Right, and this period of market exclusivity is the economic engine that allows them to charge prices significantly higher than what you'd see with competition.
And the idea is that this lets them recover R&D costs.
That's the underlying theory, yes. Recover the R&D and critically fund the next generation of increasingly complex research. Without that protection, the incentive to risk billions on a high-stakes discovery process, well, it shrinks dramatically. Okay, so we established why the list price starts high. Now, we absolutely have to examine what happens between the manufacturer's loading dock and the patient actually getting the medicine.
Right, because it's not a straight line.
Not at all. This is where complexity breeds opacity, and that opacity, frankly, is often financially weaponized against the patient.
The intermediary maze.
Yeah.
I mean, it's hard enough just listing the players involved.
It is. You've got the manufacturers setting that initial list price, the WAC. Then wholesalers distribute the product. Then pharmacy benefit managers, or PBMs, administer the benefits for insurers. Then the insurers or payers, they pay. And finally, the pharmacies dispense the drug.
It sounds incredibly complex.
And the complexity is its greatest defense, in a way. The contract terms, the specific negotiated, discounts the rebates between all these players. They are almost universally private and confidential.
So no transparency?
Very little. There's a fundamental lack of price transparency in the system, making it nearly impossible for anyone outside, including the patient, to follow the true cost of medication.
And these PBMs, pharmacy benefit managers, they seem to sit right in the middle of it all. They manage benefits for, what, almost 300 million Americans?
Yeah, over 289 million Americans are central, and their claim, their core assertion, is that they are the essential cost control mechanism.
How do they claim to do that?
They say that by leveraging their massive purchasing power, representing all those patients, they negotiate significant rebates and discounts for manufacturers.
In exchange for what?
In exchange for giving that manufacturer's drug favorable placement on an insurer's formulary, the list of covered drugs, they assert this intervention saves patients and payers, on average, about $11,154 per person annually.
Okay, $1,155 per person saved. That sounds like a powerful argument for their existence. But, and this is the big question, if they're saving so much money, why are patient out-of-pocket costs and overall drug spending still skyrocketing? Where is that saving going, if not to the person standing at the pharmacy counter?
This is the billion-dollar question, isn't it? And it really reveals the dysfunction. PBMs are often vertically integrated, meaning they're owned by or affiliated with the largest insurance companies or pharmacy chains. And they have multiple ways of, monetizing that complex intermediary role that don't actually rely on lowering the final price the patient pays.
Okay, let's detail those revenue streams. How do they make money in this opaque system?
Okay, first, they retain a share of the negotiated rebates. They secure a discount from the manufacturer, say 40%, but maybe only pass 30% to the insurer, keeping 10% for themselves as revenue.
Okay, pocketing some of the rebate. What else?
Second, they engage in what's called spread pricing. This is particularly common with pharmacies.
Not pricing.
Imagine they negotiate a deal with a pharmacy to reimburse them $50 for dispensing a specialty drug. Then the PBM turns around and bills the insurer $75 for that same drug. They pocket the $25 difference. That's the spread.
Ah, okay. Taking cut on both ends, almost.
In a way. And thirdly, because of that vertical integration we mentioned, they can direct patient volume to their own mail order or specialty pharmacies. So they capture revenue at multiple points in the supply chain, managing the benefit, processing the claim, and dispensing the drug.
So the system seems incentivized to maximize the flow of money through these intermediaries, not necessarily deliver the most efficient care or the lowest cost to the patient.
That's a fair assessment. And it brings us right to the core economic failure we talked about. The list price versus net price disconnect, the cost-sharing paradox.
Explain this clearly for us. This sounds critical.
It is the critical mechanism driving financial toxicity for patients with insurance. Here's how it works. The insurer, or the PBM, they receive those massive rebates and discounts we talked about. Sometimes these discounts bring the net cost of a specialty drug, the price the insurer actually pays down by 50% or even more.
Okay, so the insurer gets a huge discount.
Right. However, the patient's financial responsibility, their copay, their coinsurance, their deductible spending is almost always calculated based on the high inflated list price, the WAC, the price before any of those rebates are factored in.
Wait, let me make sure I understand this, because it sounds fundamentally unjust. A patient goes to the pharmacy, they're told their drug has a list price of $1,000, and their plan requires 20% coinsurance, so they pay $200.
Right.
But the insurer, after rebates, maybe only paid $500 for that drug total.
That's a very realistic scenario, yes.
So the patient is paying $200, which is actually 40% of the real cost the insurer paid, while thinking they're only paying 20% of the price.
That is precisely the paradox. The patient contributes a percentage of a price that is, well, essentially fictional in terms of the final transaction. It's a ghost price, often inflated purely for negotiation leverage between the manufacturer and the PBM.
And the patient doesn't benefit from the discount negotiation at all.
Generally, no, not directly in their cost-sharing calculation. They're financially shielded from the benefit of the negotiated discounts. Policy analysis indicates that simply tying patient cost-sharing to the actual net price could be transformative.
How transformative?
Well, studies suggest it could save nearly half of Medicare Part D beneficiaries over $100 per year just on average. For high-cost specialty drugs, the savings for individual patients would be much, much larger.
This sounds like a system that actually encourages high list prices. If I'm a manufacturer and I know I'll be forced to give a 50% rebate anyway, why not just raise my list price, my WAC, from $1,000 to $2,000? Doesn't that make the potential rebate pool bigger?
You've hit on the incentivized loop. That's exactly the dynamic. The higher the WAC, the larger the pool of potential rebates and discounts available for negotiation.
And the PBMs want that larger pool.
They desire that larger pool because their revenue is often tied to retaining a portion of it, or the spread is larger. This structure creates a perverse incentive for the manufacturer to continually elevate the list price, WAC. It enhances the profitability and leverage of the intermediaries who capture a share of that negotiated difference.
So intermediary profits are prioritized, while the patient's financial burden stays pegged to that inflated WAC.
That's the outcome. And this leads directly to another layer of patient harm, the benefit cliff and the use of copay maximizers and accumulators.
Okay, explain these. This sounds like another way the system works against the patient trying to afford these meds.
It is arguably one of the cruelest modern financial barriers, especially for specialty care. So manufacturers know their drugs are unaffordable for many patients, particularly those on high-deductible health plans.
Right, where you pay thousands out of pocket first.
Exactly. So the manufacturer offers coupons or copay assistance cards. These cards help the patient cover their share of the cost, making it possible for them to afford that expensive infusion or biologic drug and meet their huge annual deductible.
So the coupon sounds like a lifeline, right? Helping the patient bridge that gap until their actual insurance coverage kicks in after the deductible is met.
That's the intent, yes, a lifeline. But then PBMs and payers respond with programs called copay accumulators or copay maximizers.
Accumulators and maximizers, what do they do?
These programs essentially accept the manufacturer's coupon payment, which might be thousands of dollars, but they nullify its value toward the patient's annual deductible or their maximum out-of-pocket limit.
Wait, what? So the PBM takes the manufacturer's money,
Yes.
but it doesn't count for the patient's benefit.
Correct. So for the first few months, the patient thinks they're using the coupon, thinks they're making progress towards meeting their deductible. They think, okay, only $1,000 left on my $5,000 deductible. But in reality, the accumulator program means the clock hasn't moved at all. They still owe the full $5,000.
Oh my God. So what happens when the coupon money runs out?
The patient hits an abrupt, staggering benefit cliff mid-year. The manufacturer's assistance is exhausted. They suddenly find they haven't met their deductible at all according to the insurer's books, and they are immediately hit with the full, often cripplingly high co-insurance or out-of-pocket cost for their life-saving medication.
And the result is?
Predictable and devastating. Treatment delays, or critically, treatment abandonment. People just stop taking the drug they need because they face an unexpected bill for thousands of dollars.
Okay, we've laid out the structural problems, the perverse incentives, the patient harm. Now, let's look ahead to 2026. Our sources are calling this a major inflection point. Why? What happens in 2026?
Well, 2026 is shaping up to be the year where several massive forces collide. Incredible, expensive new therapies hitting their stride, and the first major impacts of the Inflation Reduction Act really taking effect in the market.
And the cost projections reflect this collision.
They do, relentlessly. We're seeing sustained, high-level cost inflation forecasts. Overall prescription drug trends are projected to hit double digits in 2026, and specialty drug trend growth specifically is projected somewhere between 6.5% and 10.5%.
And what's driving that growth? Price increases or more people using them?
Primarily utilization, more people using these expensive therapies in key areas.
Okay, let's tackle the two major market-driven cost drivers pushing this spike. The first seems to be a volume issue, the GLP-1 phenomenon, the weight loss in diabetes drugs.
Yes, the impact of GLP-1 anti-obesity medications, or AOMs, simply cannot be overstated. Consider this. Roughly 40% of people under 65 in the U.S. meet the clinical criteria for obesity.
40%. That is a gargantuan potential user base.
It is. And critically, insurance coverage for these AOMs is expanding rapidly. About 60% of surveyed health plans now offer at least some form of coverage.
So you have a hugely popular, effective drug class for a very common condition, and insurers are starting to pay for it.
Exactly. This rapid expansion of a class of high-cost, highly effective chronic use therapies, it's generating a massive wave of utilization and consequently a huge wave of spending that hits the entire healthcare system.
Okay, so if GLP-1s are the volume problem, the second driver you mentioned, cell and gene therapy, CGT, sounds like the intensity problem. This is where the price tags really jump, right? From thousands to millions per treatment.
Absolutely. CGTs represent a genuine revolution in medicine. We're moving past just managing chronic conditions to potentially offering single-dose cures for previously intractable genetic diseases or certain cancers.
Which is incredible science.
Incredible. But the price reflects that curative potential. We are seeing newly approved treatments listed at truly astonishing prices. For a specific example, a drug called Lenmeldy, a treatment for a rare condition called metachromatic leukodystrophy. It carries a list price of $4.25 million.
$4.25 million.
Yeah.
For one treatment.
Yes. And analysts estimate that total annual spending just on gene therapy products in the U.S. is likely to reach $25.3 billion by 2026.
That is a staggering figure, and I imagine the cost of the drug itself is just the starting point.
Yeah.
The administration must be incredibly complex and expensive too.
It is. Administering these complex therapies, like the latest ER T-cell treatments for cancer, require specialized hospital facilities, highly trained personnel, often long inpatient stays, intensive monitoring.
So the hospital costs are huge too.
They are, and they're compounding the drug price problem. For fiscal year 2026, the proposed Medicare-based payment just for the hospital stay and administration related to CAR T therapy is increasing significantly up to $314,176 there.
Wow, and that's on top of the drug cost itself.
That amount covers just the cost of administering the therapy in the hospital setting. It reflects the massive resource intensity required.
Okay, so we have this massive organic spending acceleration driven by these incredible but incredibly expensive scientific advances. And into this environment steps the Inflation Reduction Act. Let's focus first on the initial critical positive impacts of the IRA for patients.
Right. The IRA represents the most fundamental change to Medicare Part D, the prescription drug benefit, since it was created. Starting in 2026, Medicare gains the unprecedented ability to negotiate prices directly with manufacturers.
Which it couldn't do before.
Correct. It was legally barred from negotiating. This power applies to a select group of the highest spending brand name drugs that lack generic or biosimilar competition.
And the first negotiated prices hit in 2026.
Yes. The first set for 10 specific drugs takes effect then, and the law requires a minimum 38% price reduction from their 2023 list price.
That sounds like guaranteed relief for Medicare and its beneficiaries.
It absolutely is real financial relief. These initial negotiations are forecast to save the Medicare program itself about $6 billion annually, and they should reduce annual out-of-pocket costs for Medicare beneficiaries by around $1.5 billion.
And there's another huge protection for Medicare patients starting even sooner, right? The out-of-pocket cap.
Yes, this is arguably even more critical for individual patients. Starting in 2025, the IRA implements a definitive $2,000 annual out-of-pocket spending cap for all Medicare Part D enrollees.
So no more unlimited spending exposure for seniors on Part D.
Exactly. It eliminates the threat of truly catastrophic, unpredictable costs for seniors needing expensive medications. It's a transformative patient protection.
Okay, that is a huge positive impact for Medicare beneficiaries. But now we have to confront the other side of the coin. The massive market distortion this policy creates, particularly for commercial patients, the majority of the working population covered by employer plans.
This is the core contradiction that defines the 2026 forecast we started with. The IRA doesn't just lower prices for a few drugs in Medicare. It fundamentally restructures the financial liability within the Part D program.
How so?
It shifts billions of dollars in costs onto the plan sponsors, primarily the insurers, and also onto pharmaceutical manufacturers. This dramatic increase in payer liability within Medicare is projected to trigger a defensive market reaction across the entire commercial insurance space.
So, because Medicare plans face higher potential costs under the new structure, commercial insurers get nervous and change their behavior.
That's the projection. Commercial insurers facing this new landscape and wanting to mitigate their own financial risk are expected to tighten the reins.
Well, how will they defend their balance sheets?
Analysis shows they will likely respond with stricter utilization management protocols, basically making it harder to get approval for expensive drugs.
Like more paperwork.
Yes, things like increased reliance on prior authorizations that burdens some bureaucratic hurdle where doctors have to spend time proving medical necessity to the insurer. Also, more step edits.
Step edits, meaning try the cheap drug first.
Exactly, forcing patients to try and fail on cheaper, potentially less effective drugs before they can get approval for the one their doctor initially prescribed. And critically, we expect them to place more non-negotiated specialty drugs, the ones not subject to IRA negotiation, onto higher cost, non-preferred tiers within their formularies.
Making the patient pay a much larger share for those specific drugs.
Precisely. It's an explicit risk mitigation strategy. Discourage the use of high-cost therapies where the insurer's financial liability is highest, especially if those drugs aren't part of the IRA negotiation discounts.
So does that effectively mean commercial patients, people with employer insurance, kind of become the shock absorbers for the new system liability created by the IRA?
In many ways, yes, that's the predicted outcome. It shifts the burden. For most commercial health plans, the massive new spending associated with those high-tech therapies we discussed, the GLP-1s, the multi-million-dollar CGTs, will likely significantly outweigh any indirect systemic savings generated by the initial IRA negotiations, which, again, are primarily targeting Medicare drugs.
So even with Medicare saving money, the overall system cost, especially for commercial plans, still goes up.
That's the net result reflected in that projected double-digit cost increase we started with. Policy helps Medicare beneficiaries dramatically, which is a huge win. But the commercial market absorbs both the cost of new innovation and the defensive reaction to the shifting financial risks.
Okay, so if commercial patients are likely facing higher barriers, higher cost sharing in 2026, and we still have that underlying cost sharing paradox based on list prices, what is the ultimate consequence? In human terms and in financial terms for the whole system?
It translates directly and tragically into something called cost-related non-adherence, or CRNA.
CRNA, meaning people don't take their medicine because of cost.
Exactly. It's when patients delay filling a prescription, they skip doses, or they cut pills in half, or they just abandon the treatment altogether because they simply cannot afford the out-of-pocket costs.
And specialty drugs are prime candidates for this.
Especially those placed on those restrictive high-cost tiers we just talked about, the ones requiring high coinsurance percentages. Oral specialty drugs can be particularly vulnerable here. CRNA is the primary downstream effect.
And this isn't just a few people falling through the cracks, right? This sounds like a major public health crisis hidden inside a financial mechanism.
It is absolutely pervasive. A major national survey found that 20.2% of respondents reported CRNA in the past year.
1 in 5 Americans.
1 in 5 Americans making financially motivated decisions that directly harm their health. The specific behaviors reported are chilling. Delaying prescription fills was the most common, about 12.9%. Failing to fill a prescription entirely was 11.1%. And then taking less medication than prescribed or skipping doses altogether was about 7.9% each.
And I imagine the people most affected are those for whom taking their medication consistently is absolutely non-negotiable for their health, maybe even survival.
Precisely. CRNA disproportionately impacts patients with the highest disease burden. We're talking about individuals who already report being in fair or poor health, or those managing multiple chronic conditions, say 6 or more.
The very people who need continuous, uninterrupted specialty treatment to avoid serious complications.
Exactly. These are the patients least able to tolerate interruptions in care.
Okay, let's connect the dots back to the system economics then. Shifting costs onto patients, making them pay more out of pocket, it seems like a short-term cost-saving measure for an insurer or employer plan. But the sources are definitive. This is an economically irrational strategy in the long run. Why? Why is this short-term gain so fiscally short-sighted?
Because the short-term cost-shifting forcing non-adherence leads directly to worsening clinical outcomes, and those outcomes result in subsequent, far more expensive, acute care utilization down the line.
Give me an example.
Okay, the patient who skips doses of the rheumatoid arthritis biologic today because the copay is too high, they might end up in the emergency room with a severe, debilitating flare-up next month. That flare-up might require days of inpatient hospital treatment, maybe even more expensive rescue therapies.
So saving a few $100s on the drug leads to tens of thousands in hospital costs later.
That's the dynamic. And the sheer scale of the resulting avoidable healthcare costs in the U.S. due to medication non-adherence is just staggering. The estimate is $528 billion annually.
Wait, say that number again?
$528 billion. Every year.
$500 billion.
Yeah.
That's equivalent to the annual GDP of a medium-sized industrialized nation.
Yeah.
Wasted every single year.
Yeah.
Because we've created a system where people cannot afford their foundational prescription medication. That is an almost unthinkable economic failure stemming from what sounds like a solvable administrative or policy problem.
It's staggering, and the human toll is equally devastating. Medication non-adherence is associated with an estimated 125,000 deaths annually in the U.S.
125,000 deaths.
And it accounts for at least 10% of annual hospitalizations. You can see the immediate economic irrationality just by looking at hospital readmission data.
How so?
Studies show patients identified as having low medication adherence have about a 20% hospital readmission rate within a certain period. Compare that to highly adherent patients, their readmission rate is only 9%.
So paying for the prescription consistently is demonstrably cheaper for the system than paying for the repeat hospital stay that happens when people don't take their meds.
Overwhelmingly so. It's penny-wise and pound-foolish on a massive scale.
If the cost of non-adherence is so clearly catastrophic, both financially and clinically, why is there still such a massive intervention cap? Are physicians or pharmacists just not talking to patients about costs? Is that the problem?
Well, they are having conversations, but it seems they're often too little, too late, or lack actionable solutions. That same survey found that 80.6% of patients who reported CRNA had actually discussed cost concerns with their physician beforehand.
80% had the talk. So the conversation is happening, but it's not working.
Apparently not effectively enough. The problem seems to be timing and efficacy. These discussions often occur after the prescription has already been written, maybe even after the patient has already received that devastating price quote at the pharmacy counter sticker shock.
So it's reactive, not proactive.
Exactly. And crucially, these conversations often lack actionable financial alternatives. The doctor might say, yes, it's expensive, but they may not have real-time pricing information for alternatives or easy access to patient assistance program details right there in the workflow. We desperately need more proactive intervention at the point of prescribing, utilizing tools that can compare real out-of-pocket costs and identify assistance programs before the patient ever gets to the point of deciding to skip their dose due to cost.
Okay, so given this urgency, the financial toxicity crisis happening now, and this looming 2026 inflection point, the system clearly requires a multi-pronged mitigation strategy. We need to focus on policy reform, leveraging market forces better, and providing much more direct patient support. Right, we can't just admire the problem. Let's start with what seems like the most impactful long-term strategy for bringing down costs, but one that often gets suppressed by the supply chain issues we discussed: biosimilars.
Yes, biosimilars are absolutely key. Think of them like generics, but for the complex biologic drugs that make up most specialty spending. They are highly similar and clinically interchangeable versions of those expensive originator biologics.
And the price difference is significant.
It is. Biosimilars are, on average, about 50% less expensive than the reference originator product they compete with. And their introduction creates competition that typically drives down the average price of the original branded biologic too, often by about 25% after the biosimilar launches.
Okay, so real competition, real savings potential. What's the projected economic prize if we could actually overcome the current roadblocks to their adoption, if they were used widely?
The potential is enormous. Widespread, unimpeded biosimilar adoption is crucial for realizing estimated savings of around $181 billion over the next 5 years alone.
$181 billion. That's huge. But you mentioned roadblocks. This is where the structural barriers we talked about in Section 2 reappear, isn't it? With the PBMs.
Exactly. If PBMs continue to prioritize the high rebate originator products over the lower list price biosimilars, because that originator offers a larger dollar amount for rebates or spread for the PBM to capture.
Even if the net cost of the biosimilar is lower.
Even if the net cost to the plan would be lower with the biosimilar. If that happens, that market competition is suppressed, the savings aren't fully realized, and the system basically leaves billions of dollars on the table. It undermines the whole point of having competition.
Okay, so leveraging biosimilars is critical. Moving beyond the drug product itself, payers can also look at how and where these specialty drugs are delivered, right? This is site of care optimization.
Correct. For many specialty drugs that have to be infused or injected, the location where the patient receives that administration dictates a huge portion of the overall cost.
Why is that?
Because hospitals charge much higher facility fees and overhead costs compared to other settings. Site of care optimization is a strategy to actively direct patients, when clinically appropriate of course, away from the highest cost settings, namely hospital outpatient departments, and toward much lower cost alternatives, such as physician offices, dedicated infusion centers, or sometimes even specialized home-based infusion services. This is purely about reducing those significant administrative and overhead fees associated with high-cost institutional settings without compromising care quality.
Makes sense. And then there's the policy lever that ties back directly to mitigating CRNA, fixing that core economic failure we identified.
Yeah.
That's advocating for rebate pass-through, right?
Yes. For any payer, any employer, any plan sponsor who is genuinely serious about reducing the catastrophic downstream costs associated with medication non-adherence, policy reform mandating that rebates are passed through to the patient at the point of sale offers the single best opportunity.
How would that work?
It means the patient's copay or coinsurance would be calculated based on the net price the insurer pays after the rebate, not the inflated list price. It immediately shrinks that gap between WAC and net price for the patient.
So that $1,000 list price drug with a $500 net price, the patient paying 20% would pay $100 instead of $200.
Exactly. It dramatically reduces the patient's direct financial burden, which in turn should significantly boost adherence rates and ultimately eliminate billions in those avoidable non-adherence costs. It tackles that core paradox head-on.
Okay, those are system-level fixes. But for patients navigating the immediate crisis today, patient assistance programs, or PAYPs, are a crucial resource. How do these manufacturer-run PAYPs actually function? Who do they help?
Right. Programs run by the drug companies themselves, like the Pfizer Patient Assistance Program or AstraZeneca's AZNA, they can provide free or heavily discounted medications to eligible patients. Historically, they've primarily targeted two groups.
Who are they?
First, the uninsured people with no insurance coverage at all. And second, those covered by government plans like Medicare or Medicaid, but who still struggle with costs and meet specific low-income requirements, often something like below 300% of the federal poverty level. They act as a critical safety net for these vulnerable populations.
But, and we touched on this with the accumulators, there's a persistent, massive gap for the commercially insured population, right? The people who have insurance, maybe through work, pay high premiums, but then get absolutely slammed by a high deductible or high coinsurance for a specialty drug.
Unfortunately, yes, that's a major gap. Commercially insured patients, the very people facing those brutal high deductibles and the resulting benefit cliffs we discussed, are often systematically excluded from these vital manufacturer PPs.
Why? Why would manufacturers exclude them?
It's complicated, but the primary reasons often cited involve concerns that providing direct financial assistance to commercially insured individuals could negatively impact government price calculations for programs like Medicaid, like the best price rule, or potentially run afoul of complex federal anti-kickback statutes. So they largely steer clear.
Which leaves commercially insured patients in a really tough spot. That makes the whole administrative process of finding any help and streamlining access to it absolutely paramount, especially when someone's facing a life-altering diagnosis.
It really does. The current affordability support ecosystem is incredibly fragmented. Patients and their doctors often have to navigate a maze of different programs, manufacturer coupons, foundation grants, state programs, each with its own application, eligibility rules, and verification requirements.
Sounds exhausting and time-consuming.
It is. It requires substantial administrative effort. Finding the right program, gathering income verification, filling out complex applications. All of this often delays timely access to treatment by weeks, sometimes even months. Streamlining this process, maybe creating single application portals, simplifying income verification, reducing the overall administrative complexity is really a non-negotiable component if we want to improve adherence and ultimately save lives. Patients need help now, not after weeks of paperwork. And building on that need for timely help. Since we know patients are actively searching online for solutions to financial toxicity, often in distress, maybe right after receiving a shocking price quote at the pharmacy.
Yeah, they're probably typing, "How can I possibly afford this?" into Google.
Exactly. So the digital strategy for healthcare organizations, for patient advocacy groups, even for manufacturers providing support, it really needs to pivot. It needs to move from just providing broad general information about a disease to offering highly specific, high-intent support focused on access and affordability.
So this means being really surgical about search engine optimization, SEO, right? Targeting users who are already deep within the decision funnel. They aren't just browsing, they have a diagnosis, they have a prescription, and they're hitting a cost barrier now.
Precisely. Organizations need to create compliant, authoritative content, of course. But the focus has to be on intercepting patients who are facing those immediate access barriers. Instead of just targeting general terms like rheumatoid arthritis symptoms, we need to focus on the specific, often long-tail and question-based keywords that a desperate patient or caregiver would actually type into a search engine.
Okay, give us some examples. What are those high-intent queries that platforms really need to address directly to provide transparency and potentially prevent CRNA? What is that person typing in that moment of panic?
They are typing things exactly like you suggested. How to afford expensive prescription medication. Or they get more specific. Patient assistance programs for multiple sclerosis or financial help for cancer treatment copays.
Those queries clearly reveal someone facing an active financial crisis related to their healthcare.
They absolutely do. They're also searching for things like understanding copay accumulator programs or how to avoid the pharmacy benefit cliff. They're trying to understand these confusing mechanisms. They might search for cost-saving strategies for biologic drugs or financial assistance for rare disease treatment for my child.
So the need is incredibly specific.
Very specific. By building out authoritative digital content hubs, websites, resource pages that detail not just the symptoms and treatment options for a condition, but critically also provide clear pathways to financial management resources, assistance programs, and explanations of these insurance complexities.
You can meet that user right where they are with the answer they need.
Exactly. Healthcare organizations, patient support services, they can position themselves as the essential, trusted resource in that moment of need. This kind of digital transparency and support isn't just good marketing. It's a direct, scalable strategy to combat cost-related non-adherence before the patient feels forced to skip their very first dose. Hashtag outro.
Wow. Okay, this deep dive has really shown us that the specialty drug market is heading toward a massive, maybe unavoidable confrontation in 2026. On one hand, you have these incredible scientific breakthroughs guaranteeing continued dramatic increases in overall spending, driven by potentially curative CGTs and transformative drugs like the GLP-1s.
That's the science push. And concurrently, you have the Inflation Reduction Act introducing these really contradictory policy pressures. It absolutely shields Medicare beneficiaries from catastrophic spending with that $2,000 cap and the new negotiated prices, which is huge.
A major win for them.
A major win. But the subsequent shift in financial liability onto the plans within Medicare is likely to impose, as a defensive reaction, greater, more restrictive access barriers and utilization controls on commercial patients.
The majority of the non-elderly population.
Right. And through all of this, The single, persistent, underlying economic dysfunction remains the core threat. Calculating patient cost sharing based on that highly inflated list price, while the resulting rebates primarily benefit the payers and the intermediaries, not the patient at the pharmacy counter.
And that flawed mechanism continues to drive financial toxicity, patient non-adherence, and ultimately, as you said, potentially $500 billion in avoidable downstream healthcare costs every year.
It's a staggering figure tied to a fixable problem. To navigate this new economic reality, we really need systematic efforts. Much more aggressive adoption of lower-cost biosimilars, serious consideration of mandatory site of care optimization where appropriate, and, I think most importantly, urgent policy reform to ensure those manufacturer rebates are actually passed through to the patient at the point of sale.
Which brings us to our final provocative thought for you, our listener, to consider. Given this defensive market reaction we expect, the clear shift in financial liability and the anticipated increase in utilization management, more hoops to jump through for commercial patients starting around 2026. How will the healthcare system possibly balance its immediate desire for cost control, through restrictive formularies and prior authorizations, against the known catastrophic long-term human and financial costs of the patient non-adherence that those restrictions inevitably cause?
It's a fundamental tension.
It really is. A calculation, a balancing act that will likely define the quality, the equity, and the accessibility of American healthcare for the next decade.
Thank you so much for joining us on this critical deep dive today. We really hope this has given you the foundational knowledge needed to truly understand the complexity and, frankly, the high stakes involved in the specialty drug crisis.
Yeah. If you enjoyed cutting through the complexity with us, getting this kind of genuine, detailed insight, please make sure you hit that subscribe button. We'll be back soon with another expert analysis on the topics that matter most. We'll see you next time.